quick backdrop as to what is the HIT Commission. And Representative Gary Newell in 2006 sponsored a bill in the state of Michigan to establish the commission as representative of the health community and public in the state of Michigan, and specifically designated 13 commission opportunities within the state. Just as a quick backdrop, we recognize it doesn't cover the full breadth, and we'll introduce ourselves in a minute, but we've also suggested to the legislature at least 3 times over the past 5 years that we expand the commission to include some of the areas that are obvious to us now as we look at the continuum of care. But since then, we've been meeting regularly. I've been chair for a number of years. I was able to get a co-chair appointed in the last year, so that's been great. So what I'll do now is ask each of the commissioners to introduce themselves to you. We will conduct a meeting, and then we'll have time for public comment towards the end. And we are kind of limited on time, so I'll pay attention to that as we do that. So, Bob?
Good afternoon. My name is Bob Maluski, and I represent nonprofit organizations on the commission.
Greetings. I'm Mark Notman, the Associate Dean for Planning and Finance at the Michigan State University College of Osteopathic Medicine, representing med schools in Michigan.
Good afternoon. My name is Nick Smith. I work for Sparrow Health System. I'm here representing health plans.
Good afternoon. My name is Irita Matthews. I'm Associate General Counsel with Health Alliance Plan, and I represent Health Information Technology field.
Good afternoon. My name is Michael Chrysos. I am an orthopedic surgeon in Ann Arbor, Michigan, and I'm here representing consumers.
Hi, my name is Tim Becker. I serve as the Chief Deputy Director for the Michigan Department of Health and Human Services.
Hello again. I'm Greg Forsley. I'm the Ambulatory Chief Medical Information Officer for Trinity Health, and I here serve on the commission as representative of Doctors of Medicine. Oris.
I'm Oris Severka. I work for Residential Hospice as their Hospice Medical Director, and I'm a geriatrician, and I serve on this committee as a representative for Doctors of Osteopathic Medicine.
Hello, my name is Pat Reinbelt, and I'm the Executive Director at the National Network of Depression Centers. I serve as co-chair on this commission and representative on the MiHIN board, and I represent employers.
I'm Peter Schoenfeld, Senior Vice President of Policy and Data Services at the Michigan Health and Hospital Association, and represent hospitals and health systems.
Hello, I'm Roselle Hageman-Dingle, and I am a Director Medical Outcome Specialist representing pharmaceutical industry.
Good afternoon. I'm Megan Vanderstelt. I'm with the Michigan Department of Health and Human Services and support the HIT Commission as well as serving as Michigan's HIT Coordinator.
Great. Thank you all. Okay. One of our official orders of business is to approve the minutes from our May 21st meeting, and just for your awareness, all of this information is published on the state website under the HIT Commission folders. So we have past minutes as well as upcoming meetings and also our annual plan that we developed. So you had the minutes in your hands beforehand. I will look for a motion to approve.
I'd like to make a motion.
Thank you.
I'll second it.
Second, thanks. Any other comments? Otherwise, all in favor of acceptance as written, signify by aye.
Aye.
Opposed? Thank you. Megan, am I going to turn it over? Yes, for the update?
Well, we weren't planning an update today, just to kind of really devote our time to working towards a 2015 action plan. So in the past few months, we finalized our last year's annual report, and as part of that, we identified a number of goals and objectives which are projected onto the screens right now, which we call domains, or 6 main areas that we wanted to focus on. So we wanted to dedicate the June meeting towards discussing some ideas and action strategies to meet those goals and objectives throughout the next year and potentially onto the next year, knowing that these are incremental and a work in progress. I think it's really fitting that we learned quite a bit of the different things that are in the works across the state. We learned quite a bit about the vision statewide for health information technology and data exchange. And so from that, we were asking the commission to come together and, based on your expertise in the different areas that you represent, consider different ways in which we can continue to encourage the adoption of HIT and HIE, work on communication strategies with a variety of the different initiatives that are underway, and noting the role that HIT and HIE can play in supporting those endeavors. So with that in mind, I wanted to, well, before that, I also want to note that based on today's discussion, we will try to summarize all of that and present the Commission at an upcoming meeting a proposed roadmap or an action plan based on today's discussion. So with that, I wanted to turn it over to our Chief Deputy Director, Tim Becker at MDHHS.
All right, thanks, Megan. So I just wanted to walk through a few items with all of you, and some of this isn't new information. I know that you heard from my boss, Director Lyon, yesterday, and also Lieutenant Governor this morning. But I do want to, again, emphasize a little bit on where we're heading as the new Department of Health and Human Services. I think there's an exciting opportunity to deliver services in a smarter way with less fragmentation, as you've heard us say before, and to focus on the person rather than the various programs that we run. And with that, we have a number of exciting opportunities, I think, in IT to better serve the people in the state of Michigan. So certainly we will be looking for ways in this new department to leverage IT to connect the various systems that we have to better serve the people that use our services, and certainly you will be valuable partners in helping us attain that goal. You know, we obviously in the department are looking for ways to focus on that individual and how those services are delivered to that individual. And to that end, you know, I think a perfect example of what we've already done here is the standard consent form. We'll be looking to do more of those types of things to really help us add value and bring efficiency and consistency in the services that were provided. A couple of other things I wanted to highlight real quick before I turn it over to the Commission and ask for feedback. You've heard a little bit about where we're heading with the Medicaid rebid. I think this is a great example of where we will be doing things a little bit differently than we've done them in the past. And it does provide us an opportunity to implement the new vision. As we will implement the new Medicaid contract, we're creating a managed care system that maximizes the health status of beneficiaries through evidence and value-based care. We've expressed before the pillars, but I think it's worth repeating again. The pillars in the new contract will focus on population health management, focusing on health outcomes across the total population with specific target populations as a subset. The value-focused payment, aligning payments around improved population health outcomes, member experience, and controlling costs. Another pillar for us will be the integration of care in ensuring that Medicaid beneficiaries with complex physical, behavioral, and social service needs are served by person-centered models of care. And then also the structural transformation is worth emphasizing, designing and implementing structural changes to Michigan's Medicaid care delivery system that drive integration, value, and efficiency. And certainly I see a prime opportunity there for the Commission to have input. I also wanted to speak just briefly on our enterprise information management. For quite some time now, we've been looking for ways, not only within the department, but across the departments within state government, across the entire executive branch, to better coordinate and plug in to each other. And to that end, you know, obviously it'll be key that we protect security and privacy. Again, another opportunity to enhance customer service delivery, and certainly many opportunities within enterprise information management for process improvement, with the focus being the interoperability among the agencies, and then also that leads to the exchange with external stakeholders. Those issues really are at the top of our list. There are others, but I wanted to really emphasize those and then just kind of turn it back to the Commission here and look for maybe a little feedback, reaction, opportunities that, you know, we can partner together to meet those objectives that we're pursuing as the department. Thanks.
Greg?
Commissioner Milewski?
Please.
Yeah, great comments, and I think that's one of the strengths of this commission is the representation. You've got the partnership between all the different disciplines, including government, private sector, and all the rest, physicians, hospitals. I guess I want to put a plug in under care coordination, that goal of some of the use cases that I think are going to become more important, getting sort of the biggest bang for the buck going forward, and one of them is med reconciliation. You know, just based on my almost 40 years of experience in the healthcare arena, if you look at the sheer amount of data being processed on meds, almost every patient's taking meds, multiple meds, and the sheer number of transactions. You go into a hospital or insurance company and you look at how many transactions are processed, there's tremendous risk, but also tremendous opportunity around medication, I believe. And I know we have a use case. We're getting started around that. MiHIN's working on it. But I'd like to encourage us to continue to emphasize the whole med reconciliation as one of our earlier projects. You know, we're getting past the ADT stuff and the rest. But also, I think we may have started, but I think we need to ramp up our focus on chronic disease. You know, everything you hear, there's this wave, tsunami coming at us on chronic disease, and I think us getting out as far ahead on our work on that as possible. Any little thing we can do, I think, to impact diabetes or any of these things ought to be a major focus for us. And while I have the floor just for a second, I want to, you know, it's a unique opportunity with all these folks in the audience. I want not only want to thank them, but encourage them to help us with all this, because I really believe that there's no greater opportunity in healthcare. You know, my whole career, at the time I've walked this line right now, than this opportunity of connecting everything. You know, when we think of what's happened in our lives, I've been taking care of my 92-year-old mother recently, and she's still writing checks and has to go to the bank to cash her checks and get her cash. And I look at her life, you know, versus how I approach banking with ATM cards and never going to the bank. And so we looked at the transition that's occurred in banking, word processing. I'm old enough to remember correction fluid and carbon paper. Things don't even hardly exist anymore. And word processing now, and having secretaries versus doing all my own email and connection. You know, that opportunity exists in healthcare. It's much more complex, it's much bigger, but I want to not only thank the audience, but encourage them that I think we are right on the threshold. This commission, I think, in Michigan is helping lead the way. I'm honored to be part of it. But I do think the chronic disease and MedRec are two great opportunities for us to, you know, continue focusing on and put a real emphasis on as we go forward.
Go ahead, Peter.
I support the pillars, and I think we're on the right direction there. I think as I listened to this conference and also went back and looked at the purpose of the commission, which was around facilitate and promote the design, implementation, and operation and maintenance of interoperable healthcare into infrastructure to support data sharing. So when we talk about paying for value, we have to be able to measure it. I think there was a MiHIN slide here yesterday that only 5 to 14 of the measures go across all the different entities, and that has led to frustration, I think, in the provider community. So, and even as we talk about learning organizations, so if we could spend some time looking at how we measure quality, report it, and even examine some pilots, because this group out here is now at the stage of implementation and operation. So what are those best practices? And then how do we translate that into paying for value for those that created it? Because I think we're still falling behind in that part of our efforts.
I think that's an excellent point, one in which that falls in any number of our domains as well too, and one we certainly can work towards identifying and incorporating into the various initiatives that come throughout the year.
I would like to build on the care coordination pillar that we were talking about earlier, and put in a plug for mental health coordination. Lieutenant Governor Calley spoke of that this morning, and there are so many comorbidities between mental health and physical health that make both worse. And the costs, not only to our healthcare system, but our overall economy, are just huge. There was a recent study where there's a cost of $210.5 billion, that's with a B, to our economy from work loss, presenteeism, healthcare costs, family members being distracted. So I think it's really important that we look at any of the barriers that we have to coordinating care across those two realms.
I was actually also excited to hear from Paula, who spoke about the UP-HIE initiatives to make better transitions with long-term care facilities and sharing information. That's just a huge factor too, so I think we really need to focus in on the UP and how they advance that cause. Being a long-term care physician, that's really been it's always a big stressor for everybody. Families do expect us to know more about those patients coming in to our facilities, even long-term care facilities, and we really know nothing half the time. So that's really a key point I think we need to focus on as well. We have a really good opportunity with that. And I'll just add also really pleased to see progress with also being able to share information about our advanced directives that we have now availability for the My Peace of Mind website, that individuals are actually able to upload their personal advanced directives on the cloud, and their families can then really be able to at least retrieve that anywhere they are. And I know a physician is not available to look at those yet, but eventually we probably will be able to. So those are key things that need to be monitored and really to try to get people to encourage them to use those, use the website.
Absolutely, and I'd just kind of follow up on the discussion on peace of mind. So the statewide directory that houses advanced directives for patients is up. There's more work to be done to allow access for provider communities and to expand that access across different fronts as well too. But I'd propose that as a topic for the commission to discuss in terms of how we increase outreach efforts and related to the registry.
I'd like to second what Peter had to say about the funding as well. Not only incentives and all the cross incentives, misincentives, disincentives, but there's a lot of money being spent in this space. You know, having been I've spent time on the provider side, the insurance side, and seen it. And I'm not sure how, everybody's concerned about lack of funding, having enough funding to get everything done. And I think one of the key issues is alignment of the funding. How the money's being spent, where the key goals are. And so as we structure our goals and we get input and feedback and help others at our level as well as the next level down at the MiHIN level, attempting to get better coordination of how money across the state's being spent, so that I'm sure you've all observed the same thing. How many times have you seen a project, you've done it and spent a ton of money, and then a year or two later you're shelving it because something else has come along that's gone across that and there's a better mousetrap. And so I think as we continue to set our goals, I think the issue Peter raised about funding is absolutely critical, that we get better alignment, better coordination, to the best of our ability. And that's why I think even with the state as well, some of the stuff the state's doing is really exciting, and so that we're not duplicating effort. We got vendors in this space, we got hospitals, we've got a whole lot of people spending money. People do question, is there enough money? I think there's probably enough money if it's properly coordinated. We've got a huge task ahead of us, and the better we can coordinate what we're doing. So I think, on a routine basis, continuing to look at, how funding aligns with the goals is pretty important too.
Yeah. So you've been hearing a lot of things, and you see Tim taking vigorous notes here, because that is our role as a commission, is to advise the department on strategic direction, and that also ends up being our relationship to MiHIN. Kind of going forward with that. But I think what I'm hearing, though, also is the fact that we're beyond the point. Data used to be a competitive advantage, and we've kind of gotten past that. So now data is something that everybody is expected to share. And I think we're now getting to the point where there's other layers within the health system that are no longer competitive advantage, because they drive other people crazy as part of the health system. So patient engagement, patient experience, you talk about med reconciliation. The right answer is you get the patient and their care nuclear family involved, because they know what the medications are that are actually being taken by that individual. Because I can't know that they're taking St. John's wort over the counter for some things that are very interactive with other drugs that they might be taking. So it's really getting to that person-centric if you will. We call it in our organization people-centered, but person-centric perspective within the whole community of going forward, and figuring out how to help our clinicians work together with their partners in the continuum as well as that patient engagement level. I mean, think about things that we haven't even thought about in healthcare. There's a whole cadre of faith-based organizations that have nurses on staff, and we don't necessarily use them, and we don't necessarily connect to them to be able to bring that information to bear, because they have the ear of their community that they serve. So those faith-based organizations have a very different approach to managing populations than we do, that then gets it culturally specific, which is really where we're talking about now in that person-centered perspective.
As I listen to the discussion, I would encourage the opportunities to learn from communities that have been doing some things in Michigan and then see if we can scale it. And I think of over in Grand Rapids, an effort was taken to integrate behavioral health, the emergency services, law enforcement, so that they had the information and then could put people and make services available at appropriate settings, often lower cost. And then I think, as just to repeat it again, we have to demonstrate that the payment systems will sustain activities that actually lower payment because volume goes down. And that, I think, goes into the redesign. So if we can learn about successes, let's see if we can scale them.
So at the moment, I'm thinking there's not really a convener of, other than this kind of a forum where people talk about what's going on, what the ideas are. But I think with the learning health system development that's occurring and us partnering closely with that, the example that I've used a couple times is in the new kind of form that you mentioned in terms of the common release form for behavioral health information. There were at least 2, if not 3, avenues already started there, and when they consolidated and brought their strength together, it got through much more efficiently and effectively, so that I wasn't getting a form from this organization and a form from that organization. I got one common release form, and that's the key for us going forward, is that efficiency.
I'd even suggest I think that was a huge success story from last year, and one which I think I most certainly would recommend carrying forward. And I think the logical next step with that is how do we increase adoption of the consent form related to that particular issue, because its use, I think, is the next step in creating a process that allows for greater care coordination across physical health and behavioral health, and maybe in which an area the commission want to explore further.
Peter, you mentioned what others are doing, and Greg, you mentioned the whole person-centered, staying focused on the patient and that level. And I think something we need to connect there is how can we encourage our connection to the technology that's out there, the stuff that's being done. Everybody walking around with that smartphone constantly, everywhere you go, all of us included, everybody looking and playing with that smartphone. But apps and things that can help connect that patient. There's a lot of apps out there, but how can we connect them in healthcare so that people are interested? It makes it simple, it makes it easy, because, representing nonprofit healthcare, I think of the IHI and Triple Aim and how important that is, the cost, quality, and access. Well, the access piece for that patient-centered piece, I think with, smartphone technology, what can we do as a commission? What can all of you out here do to be open-minded, the kind of apps and the things? There's a lot of entrepreneurial spirit out there developing these things. I think the med reconciliation, I saw one, you probably saw it this week, there's a lot out there about a new app where you can list your meds, because you're saying the family knows. Yeah, the family knows, but sometimes my brother or sister may not know what I know about my mom's meds, and how do we get down to that one place where we've got one source of truth? And maybe an app, on a cell phone that can do it for us. So I think encouraging, not only the use of technology, but being very open to what technologies are out there, what kind of entrepreneurs are out there that are bringing things forth. There's a lot of people working on stuff that we need to be open to and see how we can connect to it.
I'm sorry, go ahead.
Well, at our last meeting, we also talked about privacy and security, and we haven't mentioned it right now, but clearly privacy and security has to be achieved so that people will use these connections and we can do the data sharing, and we know it goes to the right individuals with the authorization. And several things have been talked about how that's improving, and we're doing the testing. So let's keep our eye on that as well.
There's also the opportunity to further partner with the Michigan Health Cybersecurity Council that's solely focused on those particular issues as well, and in which they have sub-work groups dedicated to various issues that fit within that realm. So as ideas emerge, that's something that we could continue to take to that group as well for further analysis, more development, or to explore some potential recommendations.
You know, increasing patient registry or getting patients or people wanting to sign up for it. I think the customer, the consumer understanding some of our efforts will help along that. So I think one of our goals is to support policy or any efforts to help that happen, because they're only going to give or participate if they trust that they know what's going to happen with their data. So I think that's important. So what happens when I sign up for this registry? You know, where does the data go? How does that benefit me? Supporting those efforts in the work we do here will go a long way towards increasing engagement.
And you mentioned how does it benefit me, and I think that's really key, because it takes effort for people to create these profiles and get this information in there, and if it's all just one way and there's no value coming back to the consumer, we won't get adoption.
Right, and just wanted to add, making sure that we're supporting policies that, you know, bring this to where healthcare happens. I mean, I think we, you know, sitting around the table tend to think of things in our own industries, but making sure that, you know, we're supporting things that the customer understands and benefits their health outcomes.
So I wanted to build on a little bit of what you said about, you know, it takes the consumer time to go in and build those profiles and do, you know, into those patient portals. So you take a patient that maybe is seen at Henry Ford versus, and I'm talking about myself, so I have, you know, a primary care, I see at Henry Ford, you see a specialist at DMC, you see somebody at St. John, and you're getting all of these messages to go in and create this, you know, profile for a patient portal. And so I know we've done a lot of great work around information exchange, but of course there's a lot more to be done, and how could we make that, you know, as we move forward and help progress that, make that more seamless around, you know, consumer engagement. So then there's better engagement. I don't have to go and create 5 different profiles, or, you know, when I go in to see my primary care, he can see what my specialist has done. And I know that's the ultimate goal, but, you know, thinking of how we can get there, you know, maybe a little bit faster. And I know there was someone that mentioned FHIR, and I know that's a standard that they're looking at maybe approving for next year, and what that could maybe mean in terms of information exchange. But I know it has some issues too around security and privacy. So it's not perfect, but we're moving forward in that direction. So
I want to circle back to a point that Bob made a little bit ago. I mean, technology is ubiquitous among us, especially in the densely populated areas. But I recall in the commission, we were watching very carefully the laying of the tracks, so to speak, of high-speed internet across the state of Michigan, because there was a huge gap. And that used to be a regularly reported item that we used to receive to see where. Now, there's still the last mile connectivity, so it's not just generational about what do I use technology or phone. It's also that it may not be accessible to you even in pockets within the state of Michigan, either in the UP or in the Lower Peninsula. It's one of those where we take it as a given, and it's just that mindfulness to remember that it's not always a given. So any programs that we create want to make sure that for the technology enabled, as well as what can we do for that next step. So.
Good point.
Other commissioners, Mark, anything?
Another consideration for the commission as we explored a variety of these different topics is to consider what type of resources or other expertise or other avenues in which we can start to realize these larger goals. And what might those be? Are there other areas or groups or organizations or initiatives in which we could leverage? Something to consider, so we're not reinventing the wheel, but creating more of a coordination center point for a lot of different things.
The one thing I wanted to add about the consumerism, and it's not a new concept outside of healthcare. So are there areas where we could look at some of the mature markets that are taking advantage of consumerism and take the framework of what they've done and see how we could apply it? So, and this goes to maybe more internet-based, but when you look for a car, for example, you can go and get all the guts of when you're buying a car, the makeup of it, how much it's going to cost, each add-on feature. You can compare competitors. So the ease of use to be able to do that kind of consumerism is out there. It's just not being harnessed as much in the healthcare. So I think spend some time on maybe researching how we could leverage some of those, I guess, ideas that are already out there being used.
And I think the consumer engagement too, I think I've mentioned this once in the commission in the past, we need to continue to look for ways to plug consumers in, direct users of this stuff. Because a couple issues we talked about is engaging them and having them engaged, having them using the technology and the rest, but we've also mentioned the privacy and security. And we keep hearing that flip-flop from people. On the one hand, as an industry, you probably in the room, we've been beat up over why is it today when I go into a hospital, I get 5 people asking me the same question. And there's a variety of reasons for that, including data and data connections, but also the big one is when I get in a car accident in California, why is it that when I go in the ER, I can't hand them a card and they can then look up and know everything about my medical history if I'm unconscious or whatever. But then on the other end of the spectrum, there's identity theft, there's people making employment decisions that are discriminatory around data and all kinds of other things. People go, whoa, wait a minute, I don't want to touch my data. And I think part of it is a maturation process too, because in the banking industry, I remember first time I used an ATM, how I felt about it. And I also remember being in another country and actually going and getting money out of an ATM and being wowed, and I was real nervous about doing it. But today, I use an ATM all the time and I rarely think about any security so I think there's a maturation even in our industry because people are on both sides. So I think figuring out how we can engage consumers to move that curve along, because I think part of this is a growth. I think part of it is security, privacy, and all the rest, but there's also a maturation of people being comfortable about whose data there is. I believe that because I saw it in hospitals when we were first bringing in computer systems and making decisions around, only, and you physicians on the panel can probably relate to this, when the computer systems first came in, they only wanted the doctors who were on that case, who were maybe the primary care doctor or specialist involved with the case to see the data, and then found, that's impractical because things move so fast and there's consults and things that they said, we have to trust physicians that have data, but then have them sign off on something saying if you have access to it, you got to use it appropriately. It's not if it turns out it's not your patient, you see something. I think more broadly with consumers, that's still a piece we haven't totally figured out. It's not just privacy and security, it's also a cultural comfort level and the rest. And I think we got a ways to go down that path yet. And I think engaging consumers is an important part of that.
I don't have anything to really add, but just to amplify what I've heard a lot of people say along those lines. I think we need to help the system help the patients. Commissioner Forsley kind of talked about that. We have a lot of messages now flowing somewhere through this system, ADT type of thing. There's a lot more messaging going on with the backbone that's been created and that type of thing. But what difference is it really making at the point of care for patients as they move among the different sectors and bounce around from acute type care needs to mental health needs to chronic needs to long-term care? As they shift among the different sectors, there's still a lot of disjointed communication and planning, and patients and their advocates are left hanging oftentimes in this information void that really we are working towards fixing, but we really need to find ways to empower patients to help drive it like you challenge the folks here. We need to help arm patients and systematically help them from a system perspective to empower them to help drive this as well. But they need help with that because, as we all know, we're kind of victimized as we deal with suffering and illness of our loved ones and ourselves, and we just need to find ways to facilitate. That's a pretty broad, open-ended truism that everyone can agree with, but we have to find, I think, targeted areas where we can help get ahead of the curve on consumer engagement, the fear of the privacy stuff, help them understand that there are mechanisms to help ensure this, and also help really start making tangible differences on people's point of care experiences.
So I was just going to go back to the comment that was made earlier about kind of consumerism and what people are comfortable with and what they're used to doing, and I was kind of made me think about telemedicine as kind of that next step, and I don't know how that fits into what we're doing in terms of the HIT Commission, but someone mentioned, I think yesterday, and I don't remember the speaker, but how, or it might have been earlier today, how someone needed to go to urgent care, but they passed ERs before they got to the the urgent care, and could we have stopped that ER visit? Or I think it was maybe in a particular group, there was an increased risk of people going to the ER, and it was because they were getting to the ER before they were getting to urgent care. And, maybe if patients had access virtually to health care, the people that have access to, and have access to the internet and things of that nature, that maybe that would mitigate that going to the ER where they could see someone virtually. And so I don't know how that fits into the HIT perspective of what we're doing, but
I think it's very much in line. I think it's certainly a policy question as to where that fits in, and of course a technology one as to how it's being used. So I think it's the best of both worlds, one in which that I think should certainly be a topic.
And beyond policy, it's reimbursement.
Absolutely.
Mm-hmm.
Yes.
Well, that's the magic vision that we all have, though, with the transforming funding process. Yeah. I do need to remind us all, though, that, we forget about the fact that healthcare really is in a pioneering place with sharing of information. Because you used the car example. My car dealer doesn't know where I took it for an oil change if it wasn't part of their system. My bank doesn't know what other bank I go to, because they're all kind of within their little silos. Now, maybe somewhere behind the scenes, but that's not public facing. And yet we in healthcare are public facing with all of this information. So I agree with you, that's part of our role, is to make people feel trusting and comfortable with the fact that this information really is critical for you to engage with and for your health. So I think that's another piece of our pillars that we can kind of work with partnering others across the state to make that. And quite honestly, even across our state borders, since obviously we have a lot of bleed, if you will, not to use that word, but in terms of patients going back and forth, or even going back and forth across the state borders, especially in Michigan, now that we're finally getting into good weather. So.
Mm-hmm. Absolutely.
Our credit card companies know where we shop and what we spend and what we do.
Yes.
And they have more information about us so we could probably learn something from them about informatics on this, but something that's similar where they know everything and we access that system. But just to be a little facetious here, Greg, your analogy. But I think that engaging...
My one credit card doesn't know what the other one does.
No, that's true. And you get to choose which credit card you use. So I think the point was how we encourage engage the consumer so they can take that information. It's portable, and that information is shared easily. That's the goal that we're all trying to get to here, and how best as a commission we get to that point is the goal from the outset that I've been on the commission. We tried to start with low-hanging fruit, pick them off, as you mentioned, lay cables, gain access, encourage support. We've been picking at this away, and since I've been on the commission, it's been interesting to see how we picked off that low-hanging fruit and try to find that low-hanging fruit in these goals so we can help to engage the consumer, engage them to access, and help the provider and the clinicians engage and use that information between each other. That's what I think is the goals of our commission.
Great. Well, I think we've stirred up quite a number of great ideas. In the interest of time, I wanted to turn it over to public comment to allow our various stakeholders to participate in part of the conversation. And also I'd ask to help us recognize some of the best practices that are happening across the spectrum, and so that we can work in a coordination capacity within the commission to scale those out based on the goals and objectives we've identified and some of the next steps. I just want to reiterate that the future HIT Commission meeting, we will summarize all of the great points that have been made, including the upcoming public comment, and come back to the Commission with a proposed action plan for the remainder of the year and potentially into 2016. And with that, I'll open up to public comment.
you want me to go first? I'm Tim Pletcher of the Michigan Health Information Network. One of my questions for the commission is what can this audience do to help you with your agenda? Is there anything you would want from this community that we might be able to aid you?
Well, it's interesting, Tim, you mentioned that because the last talk talked about some of this quality initiatives and some of, for example, the marquee and some of the other data, that engaging early on in the process, like in other words, where we as a commission just kind of head off some of the things that might be difficult later on. If you can start out engagement early, then with people like you, Tim, to try to share that data, then you head off a lot of problems later, I think, because some of these quality initiatives are pretty far along down the line, and so once you get far along down the line, it's sometimes harder to change. So engaging early, I think, is an important feature. So.
One other thing I'd like to add is, and it's a great question, I think, because I'd like to ask all of you to go out and drop the shields, the force shields, whatever they are, the competitive juices and all the rest, because we all have that, and yet in this space, to help everybody's health at times, I think we got to collaborate, we got to cooperate at a level we haven't in the past. You mentioned the banks, whoever it is, this is about people's health. And certainly there are good reasons for competition, and competition sharpens the sword, and it got its appropriate place. But on a lot of this stuff too, you know, data is power, and holding on to information and data and not wanting to collaborate or cooperate or give it up, I think unless the organizations in the room are willing to drop their guard a little bit on this stuff and work together, we're not going to get it over the finish line.
And just to kind of close the loop on Tim, once upon a time we thought that there should be kind of a summary of all of the patient safety activity that's happening in the state, and recognized that that was going to be a daunting task, because if I'm going to sit there and look and see if somebody's working on something, that would be really helpful, but to do that would be almost impossible. So I think your forum within MiHIN and the community of health information exchange activity becomes one where no idea is a bad idea, let's talk about it. And so using your blogs, using your others to kind of help cultivate that information, and then sharing that with the commission would be wonderful.
I had one other, I guess helping us understand the demographics of the population we hope that all this interoperability serves, that will go a long way towards helping us on the work of the commission. I know when we were looking at the standard consent form and hearing some of the impediments and obstacles that some of the various agencies had, really helped us look at that form and look at it from the eyes of the various stakeholders who would be using it. So any input you can give from your various industries on you know, some of the populations or the demographics of who we want this to help serve would be helpful.
Roselle, need a mic.
Is this on now? Yeah. Okay. I just wanted to not beat a dead horse, but just build on the whole, the comment on breaking down the walls, and, you know, this is people's health, and, you know, it's the right thing to do, and having that information available to treat patients well, and not only thinking about it that way, but also, you know, that could help break down some of the inefficiencies within the system, because if a patient is seen one place and it's already had imaging or whatever test done, but then they show up in another place, and now we're starting over again. And so kind of thinking about the waste that we see in healthcare, even with all the changes that, you know, that we're doing now. And so not just breaking down the walls because it's a good thing to do, but also, you know, good for the patient, but also just, you know, overall for society, the cost of healthcare.
Again, another amplification of Rita's comments. I mean, again, the importance of, you know, you all represent various stakeholders, and we have a use factory out there, and we're churning out, we're identifying use cases. We sit here and we talk very high-level policy, and there's a lot of moving parts to this, but policy only gets real on the ground when it gets implemented, and we need people representing stakeholders that can give us, ideas on what we can target our energies or the state's resources and other resources that we can bring to bear with your help and the operationalization of these ideas, because it happens on the ground with people making changes in how information is used to help improve population and individual health. So it's kind of all abstract in a lot of ways as we meet at the commission and talk, but the real rubber hits the road based on the ground in terms of how you operate and who you represent and who you serve on every day. So it's just an amplification and reinforcement of what people said, but acknowledgement that the system is really comprised of people on the ground doing things, and we need help in identifying targeted areas where we can get the low-hanging fruit again targeted and really operationalize some of this stuff that can help us move the agenda to really, again, make a difference on the ground.
I think there's opportunity to also help the operational performance and efficiency of the organizations that are doing these activities. And I'll give an example that I heard from some hospitals, that the state is doing a lot to digitize its services and share between departments, and you're collecting immunization data. I know you're working on it so it can be queried and then it can come back out. That isn't possible yet, or it's close to you can do it. But I know in hospitals, most of them are requiring their employees to all be immunized, and that's all paper. If they could also document, and I think right now pharmacies are only required to report under 18, but if they could also report adults, but that means we need a consent that you can share that with an employer. But that would increase operational and lower cost for organizations, but there's probably a lot of ideas like that to apply what is now being implemented into operational improvement.
Good.
An excellent idea.
Good discussion.
Well, I think we're out of time, but I want to thank MiHIN for allowing us the forum for the HIT Commission to meet for our June meeting. And I'm always open for any other questions or comments that come in. I can serve as a proxy to the Commission as well, too. So thank you very much.
And thank you. The meetings are open if you ever wanted to attend, and I'm going to call us to adjourn. Thank you.
Isn't this where you ask everyone to introduce themselves in the audience, Greg? You ask everyone to introduce themselves in the audience this time.
Yeah, I decided that would probably be a good form of this one. So thank you all. Short break, I think, right?